thanks to everybody who's joined today so that I can teach you all a little bit about what I deal with on a regular basis, day to day, treating patients with urologic problems. As you can see on the screen, I treat a really wide variety of urologic issues. Near and dear to my heart is female pelvic floor reconstruction, urinary incontinence, benign prostatic hyperplasia, or enlarged prostate surgeries. So I treat a really wide variety. I treat a lot of kidney cancer, bladder cancer, etc. Today, what I want to focus on is talking to you about bowel and bladder problems, and specifically incontinence, urinary retention, and a variety of those things. So if you started this webinar and thought, oh, I better go to the bathroom before this starts, because otherwise I might not be able to make it through every last second of this very riveting talk, then you're in the right place, because I'm going to talk to you today about a problem called overactive bladder, which is a super common problem that millions of Americans deal with. If you deal with urinary retention, where you're having trouble emptying your bladder, or if you're dealing with fecal incontinence, which is another really bothersome condition, which is quite common, we're going to touch on all of those tonight. And I want you to know from the beginning that you are not alone, and there are a lot of things that we can do to help these problems. And you should seek help if this is something that's disrupting your quality of life, because so many patients don't. That it's really sad. You know, I'm so happy to take care of these patients, and they are so thankful generally. So it is really quite a joy to deal with this, because we make such a big impact on patients' quality of life, and it's really not hard stuff. So getting started, overactive bladder is a super common condition. As I mentioned, 50 million Americans in the United States deal with overactive bladder. An additional 20 million have fecal incontinence, and I'll get into the exact details of those in just a minute. But only half of those patients with more severe symptoms ever seek any type of treatment. Oftentimes, primary care doctors don't know to ask these questions. Patients are embarrassed to bring it up, and so it just kind of goes unrecognized and therefore untreated. And I've talked to many primary care physicians who are friends of mine to sort of spread the word, and I hope to teach you guys that it's something that you should feel comfortable talking to your doctor about, or coming to your urologist, talking to your urologist or gastroenterologist or colorectal surgeon about, because there really are things that we can do to help. So your symptoms may be, may not fit into one specific category, or you may have symptoms that fall into each of these categories, or some in the middle. But we'll start with overactive bladder. This is the sudden, compelling desire that makes you feel like you need to urinate, and you need to urinate right now. You feel like you got to stop everything you're doing to get to a toilet, or you might have an accident. Urinary retention is the inability to completely empty your bladder or empty it at all. Some patients in urinary retention need to catheterize themselves, or have a catheter in or a tube in their bladder to drain urine if it goes on for an extended period of time. Fecal incontinence is the involuntary loss of stool. So instead of urine leaking out, stool leaks out. Imagine how uncomfortable and embarrassing that can be for patients. The bladder normally functions as a part of the central nervous system. And the bladder fills throughout the day, somewhat dependent on fluid intake, that is going to be also impacted by other medications like diuretics, or if patient has congestive heart failure, or if they've got peripheral edema, those things can play a role. Kidney function can play a role. But you know, oftentimes one of the more common issues that we see with patients who have overactive bladder and they're urinating frequently is their fluid intake and the types of fluids they're drinking. When the bladder starts to get full, there are nerve signals that are sent to the brain that then triggers an event to happen that starts in the brain, and signals go back to the bladder to get the bladder to contract. And this is a very coordinated series of events. For proper bladder functioning, it's sort of the most basic way that I can describe it. You have to think of it in two phases. There's the storage phase, and that's where your bladder needs to be able to accommodate to fill with urine. And during the storage phase, the bladder needs to be calm and relaxed. The pelvic floor muscles need to be tight. The urethral sphincter muscles need to be closed. This allows your bladder to hold that urine without it just constantly leaking out. This allows it to fill. During filling, which the normal bladder capacity is about 400 cc's, 500 cc's, so a can and a half of Coke or so, if you will. those bladder should start to send some subtle signals that your brain will sort of interpret for you that, oh, I think I might need to urinate in the relatively near future. But you should have enough time that, let's say you're driving down the highway to go visit some family or friends. You should be able to find the next exit, pull off, walk into the gas station, wait in line if you need to wait in line, walk into the bathroom, pull your pants down, sit down on the toilet, and then urinate. That should all be able to happen. And if you're not able to make it, you're having to pull off on the side of the road, or you're waiting in line, and as soon as you hear the toilet flush or somebody starts to wash their hands, your urine just starts coming, that's abnormal. The bladder is starting to contract before you're in a socially acceptable position for that to happen, and that's called urge incontinence, okay? The second phase of bladder function is the emptying phase, okay? So at this point, and this again, very coordinated, starts in the brain, okay? So brain sends a signal, okay, now it's time for us to empty. The pelvic floor muscles need to relax, and that happens first. Then the bladder should squeeze, and the bladder should squeeze long enough and strong enough to completely empty the entire contents of the bladder. Plus or minus, you know, some people will retain a little bit of urine, and that's not too abnormal, but you get what I'm saying. You need to fully empty your bladder so that you feel empty. Then the bladder relaxes. Then the pelvic floor muscles, the urethral sphincter muscles contract again, and the cycle starts over. And that's the normal micturition cycle. That's the fancy word for peeing, okay? When something goes awry in that series of events, that's where we'll start to see problems. And overactive bladder, you know, technically is really this urgency symptom, but there can be issues concurrent to that, or symptoms concurrent with that. Urinary frequency is one of them. You can have frequency without urgency, and you can have urgency without frequency. Some people may only need to urinate 5 or 6 times a day, which is within the realm of normal. But when the urge comes, it comes on out of nowhere so strong and they can't control it. So that's abnormal. Urinary frequency by definition is urinating 8 or more times per day. Urinary urgency, we've touched on. Urge incontinence is when you leak in this scenario. Nocturia is the term for having to get up at night to urinate. And typically 0 to 1 times at night is normal. 2 or more times is what we consider abnormal. And there certainly are going to be multiple factors that play a role, especially with nocturia. It's rarely just a bladder problem. It's rarely a prostate problem, solely a prostate problem. It tends to have multiple different factors. I could speak on that for an hour in and of itself. But it can be part of the OAB symptom complex. So we kind of touched on this. This is the overactive bladder is this abnormal communication between brain and bladder, and we can use those 2 phases of bladder functioning to achieve improvement in symptoms, and by a variety of different ways. And I'll get into that in a moment. With incontinence, you got to realize that there's also different types of incontinence, and urge incontinence is just one type of incontinence. And oftentimes people don't really realize that there are a variety, and they're caused by different reasons. So I do just want to touch on this, that there can be stress incontinence. Stress incontinence is not you had a bad day, or you know, you're late and you're in traffic and it's stressful. It's something that causes an increase in intra-abdominal pressure, and that pressure is the stress, okay? And it's pressing on the bladder. And typically this is going to be a cough or a sneeze or a hard laugh or a jump exercise, for instance. That's going to cause this increase in intra-abdominal pressure. It presses on the bladder. The urethra can't close tight enough, and it's the pressure, the external pressure on the bladder, that forces urine to come out. So this tends to be squirts of urine, and sometimes it's a lot, sometimes it's a little, but it's during that activity. And as soon as that activity stops, so the sneeze is done, the leak doesn't continue going. Whereas with urge incontinence, it tends to be, you know, that bladder spasms and it squeezes, and it usually squeezes until it empties. So these tend to be much more profound incontinence episodes. You know, flooding episodes of incontinence is more likely with the urge related incontinence, whereas the stress incontinence tends to be more sporadic or smaller amounts that shoot out and then stop when your cough stops. And they can happen concurrently, not typically at the very exact same time, though that can happen, but more that patients can have stress incontinence, and they can also have urge incontinence. And when that happens, we call that mixed urinary incontinence. There are a few other types of incontinence, like overflow incontinence, which happens in patients that have urinary retention, or they're not emptying their bladder all the way and they kind of leak off the top. But it's not because their bladder is necessarily contracting, it's just there's nowhere else for it to go. Or functional incontinence, a few others that I'm not going to touch on today. This is what I want to focus on for today because these are the most common. And it's important to understand that, again, the overactive bladder urge incontinence is a physiologic problem of the bladder. And sometimes it's a central nervous system issue. It's more common in patients with neurologic disorders, or in patients who've had strokes, or in patients who are diabetics, for instance. Stress incontinence is typically an anatomical problem of the urethra, of the sphincter muscle surrounding the urethra. Sometimes there's an inherent deficiency of the sphincter muscle. Sometimes the issue is related to laxity in the pelvic floor, especially around the urethra, maybe from prior vaginal deliveries or multiple pregnancies or surgery that has affected the integrity of the pelvic floor structures. So very different problems, different causes, but often happening at the same time and getting addressed concurrently or in stages. All right, I want to quickly touch on the bowels. I am not a colorectal surgeon. I'm not a GI doctor, but I do help a lot of patients that have fecal incontinence once they've kind of run through their options with their GI doctors or their colorectal surgeons, because we can do a procedure to help with fecal incontinence, a surgery that's very similar to what we do for urinary incontinence. So we do end up seeing patients for fecal incontinence. We're happy to help them as best we can. So typically what you need to know about the rectum is it's kind of similar to the bladder. Again, controlled by the central nervous system. You can't will your bladder to work. You can't will your rectum to work. These things are all controlled by the central nervous system. And as that rectum fills with stool, stretch receptors are activated in the wall of the colon. Nerve signals are sent to the brain, making you sense that you might need to go empty your bowels. Once you get to the bathroom, your pelvic floor muscles need to relax. The bowels then start to contract. We call that peristalsis, and that's how the bowels empty. Then they relax. Your pelvic floor or your anal sphincter muscle at that point will contract again. That's how you can hold stool in the rectum without constantly leaking it out. Well, sometimes that's not functioning normally, and patients can have incontinence of stool. And this could be liquid stool, it could be solid stool, or it could be mucus. Symptoms of urge incontinence, passive incontinence, or soiling, if you will, include that sudden compelling desire to have to poop, the urgency with incontinence, so the inability to maybe stop that urge to have to use the bathroom, and then it just comes out, but you sense that it was about to happen, you just couldn't get to the toilet in time. And then there are patients that have passive fecal incontinence where they really didn't have any sensation that this was about to happen, and then all of a sudden they've soiled themselves. So these are extremely distressing to patients, these types of problems. And again, not uncommon. 20 million Americans have to deal with this. And this, the fecal incontinence, the urinary incontinence, they can all affect quality of life pretty dramatically. Patients feel inhibited from being able to go socialize with friends, especially with friends who don't know about their issues with these things, or to go to new places where they may not know where the restrooms are. They don't know how to get themselves out of a bad situation if they're in one. They feel limited in their physical activities. They may feel limited in their sexual activities, and that can put strain on relationships. They may have troubles at work, having to go to the bathroom so frequently, with their bosses feeling like they're not being productive. Oftentimes I have to give patients, work notes to say, look, they've got to be able to go use the bathroom more frequently than you might think is necessary. It can cause patients to feel depressed or guilty. They can be self-conscious because they feel like they smell, and oftentimes they do. They can have issues with having to where spending a lot of money, I guess is the right way to say it, financial burden from the cost of pads or diapers or special bedding, or having to do laundry 3 or 4 times a day because they're changing their clothes so often. So these are some of the quality of life ramifications that we see from all these incontinence issues, both bowel and bladder. So it's really important to know that this is not generally something that you've done wrong. It is not necessarily a normal part of getting older. It is often associated with getting older, but that doesn't mean that it's normal. It's not just a part of being a woman. It's not just a part of menopause that you should have to deal with. It's also not just a part of being a man and just a part of prostates getting bigger and getting older. and it's not, something that you did, right? So there are, again, so many people feel shamed about this and they feel like it's their fault and they never seek treatment. I'm here, preaching to try to get people to come in more often to get this dealt with. They can have a much better quality of life. So we're going to move to talking about some of the treatments that we have available for this. And some of this is a bit repetitive because a lot of the stuff, as you know, you need to go in and talk to your doctor and get evaluated and have a physical exam, and starting with your primary care physician if you're comfortable with that or if they're receptive to that. But if not, a urologist, or again, for the fecal incontinence issues, you may start with your GI doctor. You may start with your colorectal surgeon if you have one. But just getting in the door and starting the conversation is important. Oftentimes for these types of problems, we may have patients keep a bladder diary. So we get a baseline assessment of their symptoms. We may have you fill out symptom assessment scores in the office. And oftentimes, not just at one visit, but at follow-up visits as well, so that we can keep track of our progress and how the things that we're trying are working. We may need to do some diagnostic tests to really understand, is there some underlying cause here that's correctable that won't necessitate long-term treatment, with other things. So sometimes it's a urinary tract infection that's gone undiagnosed. Sometimes it's a stone in the bladder. Sometimes there's a diverticulum, a variety of different things that may be contributing to your symptoms. Undiagnosed diabetes, super common to cause overactive bladder symptoms. I diagnose diabetes probably 8 times a year for a patient that comes to me because they're peeing all the time, and it's really their really high sugar levels causing sugar in the urine, and the water follows it, and they have constant frequency and urgency, probably a lot of UTIs. That can cause your overactive bladder, and getting the diabetes under control can make a big difference. So there's a lot of things we got to exclude to cause some, to then say that this is just pure overactive bladder. And oftentimes it's not pure overactive bladder, it's overactive bladder that's got some other contributing factors that we're trying to co-manage with your other physicians. When it comes to treatment, oftentimes the initial steps, if you haven't already worked through this with your primary care doctor and you're making it to our office, we're going to counsel you on lifestyle and dietary changes, changing the fluids that you're drinking, the amount that you're drinking, cutting back on the known irritants in the diet, the carbonated beverages, even carbonated water, caffeinated beverages, teas, especially the caffeinated teas, coffees, acidic stuff, tomatoes, citrus fruits, vinegar-based products, those sorts of things. Alcohol, of course. Those types of things tend to be very irritating to the bladder. And there's a very long list that we give out to patients. And I always tell them, read it when you're at home. Don't read it when you're here, because I don't want you to get mad at me. But it's not meant to be sort of a mandate that you can't ever have these things. It's meant for you to look at it, evaluate your diet, see if you can identify if you have any specific triggers that you may be able to cut back on. But it's all about finding a balance. Again, this is a quality of life issue. It's not life or death. Having to get up and pee 3 times during a movie doesn't kill you. It just drives you crazy, right? Well, maybe it drives you crazy enough to give up the 3 Cokes that you're drinking during the movie, and maybe you won't have to get up and urinate so often. So it's things like that with lifestyle changes. Weight loss, if you're overweight or obese, can certainly help. And then there is going to be prescription medications that come into play. Typically, by the time patients are getting my office, hopefully they've tried some of those things, but oftentimes they haven't. When it comes to prescription medications, we can go back to that basic physiology, understanding of how bladders work, to understand how the medications that we use function in this space to help overactive bladder symptoms. I'll get into those in just a little bit, in some more details, but I do want you to know that there's other advanced therapies like Botox injections and sacral nerve modulation and tibial nerve modulation. And I always give this information to patients at their very first visit. I think that's important. I want them to know that if the first few things that we try aren't working, please don't give up. Please keep your follow-up appointment, because there are other things that we can do. And some of these things are, in my opinion, way better than the medications. Get you off of an oral medicine every single day for maybe the rest of your life. Give you more relief than you might get from medications. Oftentimes we have to try those things. We have to, kind of follow the rules and the proper steps. But moving on to some of these therapies in the third line realm can oftentimes give you better relief with less side effects and happier patients. So we'll touch on each of those individually. Urinary retention, again, slightly different. This is kind of the opposite problem, if you will, where patients just can't empty well enough. And it can have some of the same underlying initial instigating factors. You know, it can be diabetes that can lead to this, neurological conditions can lead to this, prostate enlargement that's gone untreated for a long period of time can lead to this. So it's really important with urinary retention that patients get a good history, a good physical. They probably are going to need to undergo some diagnostic tests, maybe even more so than with overactive bladder. Specifically tests to understand how much squeeze does your bladder have, if any at all. Are there any structures blocking the urinary channel? This is really important in men who have a longer urethra, more prone to strictures or narrowing. They've got a prostate that tends to grow big as they get older. It can cause blockage of the urinary channel. So oftentimes men that have urinary retention, it starts with some sort of a blockage, typically the prostate, and we need to make sure that gets unblocked. And if you're still not able to urinate after trying to unblock it, there are some other things that we can try to get your bladder working again. So for a retention, if it's already progressed to that point, you've not already been on oral medications, we'll certainly try that. But again, if it doesn't work, don't give up. There are things that we can do beyond just oral medications to try and get your bladder functioning again. Oftentimes it has to be done in stages to get it right. And then with fecal incontinence, again, you're gonna probably need to keep a diary of your symptoms, documenting how often it's happening, what's the severity of it, are there any dietary things that you've noticed that maybe bring on your symptoms. With dietary changes and some pelvic floor activities or exercises, sphincteric strengthening exercises, over-the-counter antidiarrheal medications, an up-to-date colonoscopy. If those things aren't working, then we can get into some minimally invasive surgical therapies that work really quite well for this, pretty dramatic. So that's where I get to play a big role in fecal incontinence, pretty rewarding. Okay, so initial treatment for overactive bladder. With OAB, oftentimes you can use your pelvic floor muscles as a contraction of the pelvic floor muscles to try and help inhibit that bladder contraction. So God built us with a very smart reflex mechanism built in that says when the pelvic floor is closed, the bladder should not contract. The reason for that is if you think about it, if your pelvic floor is closed, let's say there's no outlet, nowhere for bladder for urine to go if your bladder squeezes. The only place that it can go is it either causes the bladder to pop, which is bad, and thankfully that rarely happens, or that urine can be pushed up back the ureters, which are the drainage tubes for the kidney, back up the ureters into the kidneys, but over time that causes kidney damage. So when the pelvic floor is contracted, there's an automatic reflex mechanism that's built in that tells the bladder to calm down. Please stop squeezing. Again, when I was explaining to you the physiology of how bladders work, I made a point to say that when it comes time to empty your bladder, the first step is your pelvic floor muscles relax. That gives you that open channel. Then your bladder contracts. And then it contracts all the way, long enough, hard enough to empty the contents, it relaxes, and then the pelvic floor contracts again. And so it's built like that in a very sequenced event so that it doesn't cause this extra pressure on your bladder, which can cause kidney damage, okay? Well, we can use that to our advantage, and we can do some suppression exercises, Kegel exercises, which are pelvic floor contractions. When we feel that urge coming on, we can tighten the pelvic floor. If you don't know what a Kegel is, it's a contraction of the pelvic floor where for a woman, it would feel like you tightening around your partner during intercourse, or for anyone, male or woman, if you have to pee or you're in the middle of peeing, let's say, and somebody walks in the room and you want to stop your flow of urine, that's a Kegel. Or it also feels like contracting and pulling your anus up and in, okay? I know these are unusual ways to describe it, but some people get it in different ways when I describe it like that. That's a Kegel. So if you have that urge come on, you can tighten your pelvic floor and do some deep breathing, and oftentimes that will get your bladder contraction to pass. We can have you work on bladder retraining schedules. Some people are in this sort of habitual sort of rhythm of having to go urinate every hour. Some people wake up at night for completely other reasons, and then they go urinate and they come in saying that they have to get up to urinate all the time, but really they're waking up for other reasons, but they're in such a habit of just going to urinate because they're up, and well, I don't want to wake up in another 20 minutes having to urinate, so I might just go do it now. But if they were sleeping more soundly through the night, if they didn't have the distractions of their partner snoring or the cat jumping on the bed or the light from the neighbors shining in through the window, they may not wake up. So there's some things there, especially with the nighttime urination. With bladder retraining, we also will have patients learn to try to sort of delay voiding if they can just try to push it an extra 20 minutes. I'm not suggesting that's the right thing for everybody, but for some people where we've evaluated them and we think that's the right thing, we'll have them work on that. And oftentimes we'll send patients to pelvic floor physical therapy to really help with this, because they've got a lot more time to spend with patients than I do working on these types of exercises. The lifestyle changes I touched on, but it's going to be monitoring fluid intake, cutting back if you're over consuming. Oftentimes a bladder diary is very helpful in determining who's over consuming. Oftentimes patients don't realize that they're way over drinking when they've got this problem. Limiting some of the more irritating foods in the diet. The medications that we frequently use, there's two classes. There's beta-3 adrenoreceptor agonists. I just call them beta-3 agonists, okay? Of which there are two on the market. One is called Myrbetriq or Mirabegron, and the other is called Gemtesa. Myrbetriq has been around since about 2012, if I'm not mistaken, and Gemtesa just came out last April, so it's not even been on the market for a year yet. These medicines are great. I like them in terms of oral medications. They're my preferred options, but they tend to be a little expensive. Sometimes insurance companies don't cover them right off the bat. They're getting better, but they don't recover them right off the bat until maybe you've tried some alternatives. But these medicines work during that storage phase to help keep the bladder relaxed, okay? So they work, in my mind, I think of it like our bladder should be in the relaxed phase 97% of the time or more, right? Because we're only, hopefully, not urinating more than 3% of our life or in a given day. And those are just percentages I made up right now, but you get the point, right? So this is to help keep that bladder in that relaxed state. It does not impair contractility, or it should not impair the ability for your bladder to contract when we want it to, okay? And because of this, the side effect profile is quite different than the anticholinergics, which I'll get into a moment. The Myrbetriq may cause some patients to have a slight rise in blood pressure or heart rate. The Gemtesa shouldn't do that. These are, pretty well tolerated medications and well-selected patients. They work quite well. The anticholinergics, of which there's about, 10 or so on the market, they work to help prevent the bladder from excessively contracting. So it's working on that contractile phase. And they can, because of the way they work and the receptor they work on, cause a more broad variety of side effects, but they can cause dry eyes, dry mouth, constipation, and there is some concern about them potentially causing cognitive decline. And that data is hard to really tease out. I'm not going to get into it too much, but there's certainly that concern there. And I prefer to use the others for those reasons, and the side effect profile is just less tolerable than anticholinergics. But the reality is that there's the FDA approved the use of these two medications, specifically Myrbetriq and another medicine called Vesegir, in combination, that we're using both the relaxed state and the contractile state to help this problem. And they work better than either one alone, but at the risk for higher side effects. So, some patients will start with one or the other. Sometimes it's dependent on their insurance. Sometimes it's dependent on their other medical problems, i.e. if they have high blood pressure or they are on a medicine that says they can't be on, one of these options, then we'll choose the other. I typically would start patients on a medication for about a month. I think we're going to know within a month whether or not the symptoms are going to respond. If you give it a good solid month and there's no improvement, we move on to the next thing. We may choose a different medicine within the same class, or the different class altogether, may try one more month. Generally, I'm not someone that just keeps prescribing medications. I'm really there to try and help find the solution and moving on to other things. I'm not, in general, somebody that wants to have patients on oral medications and their potential side effects long term. But if they're working, they are the right thing for a lot of patients, and so we certainly will give them a try. Moving into the advanced therapies for overactive bladder, and this is all going to apply to urge incontinence as well. I'll get to the stress incontinence and the fecal incontinence in a little bit, but OAB and urge incontinence we can kind of bundle together here. The first advanced therapy I'm going to touch on is called percutaneous tibial nerve stimulation. This is at this point anyway, an office-based nerve stimulation where we deliver gentle electrical stimulation to a nerve that's located in the leg. We can access it just by placing a tiny little needle. It's similar to an acupuncture needle in the leg, kind of above and behind the ankle bone. That needle is connected to an external stimulator unit, and you hang out in the office, read a book, call a friend, chat with the nurses. But for 30 minutes, you sit there and this nerve gets stimulated. This nerve travels up the leg, and if you want to think of it this way, it kind of intersects with the main bladder nerve, which is the sacral third nerve. And there's crosstalk between these two nerves. So by stimulating the tibial nerve, we get stimulation of the sacral nerve or the pelvic floor nerve, which controls bladder function. And over time, we can start to see improvement in urgency, frequency, and incontinence. This is not an immediate effect. I always warn my patients, look, we're going to give it 12 weeks, a once a week session for 12 weeks. You may not see anything for the first 10 weeks, maybe 12 weeks. I mean, some people will start to respond earlier than that, but there certainly are patients that see absolutely no difference until week 12. And then it's like, boom, a light goes off and they're like, oh, I'm better. So we give it 12 solid weeks. I tell patients, just please commit to the 12 weeks. And then we reassess. And if it's working for you, then you go on to a monthly maintenance session. Same thing, 30 minutes once a month, typically. It works at about 70% of patients who are properly selected. So, there are going to be a handful of patients that go through the 12 weeks and don't see enough improvement or any improvement to continue monthly treatments, but it is quite helpful in a lot of patients. And there really is minimal risk to doing tibial nerve stimulation. And when you compare it to some of the alternatives, you'll understand what I mean by that. But, it's really, other than the stimulus, similar to like a TENS unit, it's really not too uncomfortable. There's minimal risk for infection. There's minimal risk for bleeding or complications of that nature. And there's no surgeries involved. There's no implants, etc. So PTNS is the right option for people who are maybe less risk tolerant and who have the time to come to the office visits and who can sort of commit to that 12-week initial trial. Chemical denervation of the bladder, we use Botox for this. This is the brand name of onabotulinum toxin A, which I will not quiz you on, but that is basically a paralytic agent. And it's a very potent paralytic agent. We use it in tiny, tiny doses around the body for a variety of different issues, primarily muscle spasm issues, right? So overactive bladder is kind of a spasm of the bladder muscle where it's, when it's overactive, it's contracting, spasming when it shouldn't. We can use Botox to partially paralyze the bladder. The goal is partial paralyzation, enough that your bladder calms down, but still working, able to squeeze well enough to allow you to empty your bladder. This is a really effective treatment, but it has some different types of risks. And that would include, number one, urinary retention. Retention meaning you can't urinate. And that is a real possibility for patients who undergo Botox injections. It only happens in about 6% of patients who we put sort of the standard 100-unit dose in. But for those 6%, if it happens, it's real. And there may be a time frame where you might have to catheterize yourself to empty your bladder or have a catheter put in until that bladder muscle starts to regain its function. The deal here is that it does wear off, so even if the Botox is working great and you're like, hallelujah, this is the best I've felt, with regards to my bladder in ages, there's going to be a time when it wears off and you're going to start to feel your symptoms coming back, and you have to keep the Botox up. Botox is done typically as an in-office procedure where we put a small camera in the bladder, and through that camera, we pass a tiny little needle and directly inject the medicine into the bladder muscle. We often will bring patients in to drain their bladder, put some lidocaine or numbing medicine in the bladder, let it dwell there for 10 or 15 minutes prior to the procedure, Sometimes we use nitrous oxide for patients that are nervous, or if they're really nervous or have had bad experiences, we can do it with them asleep. But it's a quick office-based procedure. You can get in and out, go about your day the same way as you came in. And on average, it needs to be done about every 6 months. There are patients who only get 4 months out of it. That's pretty rare. There's patients that get a year out of it, but again, the average is 6 months. So whether it works great or whether it's worked too well and you're kind of in a pinch for a little while until it wears off, and typically it's fairly transient, maybe 4 to 8 weeks of having some difficulty emptying your bladder, maybe not that long, but theoretically 6 months, that could last, but it will wear off and you'll be right back to where you started. So there are a lot of people who choose this option. There's a lot of people who say, look, I'm not willing to have to catheterize myself if I can't urinate, and who shy away for Botox. Okay. And then our last option in our third line therapies is what's called sacral nerve modulation. And sacral nerve modulation has been around for decades. It's really gone through some significant changes in the last few years. We've got really nice technology now that's driving sacral nerve modulation, and the technology this keeps advancing. So we're seeing new stuff come out all the time. But in general, sacral nerve modulators, of which there's 2 brands on the market you may have heard of, one Axonics and the other is Interstem, made by Medtronic. They're very similar with some differences mixed in there, but they work in the same sort of way. Nobody can actually to the T explain exactly how this works, but it helps to reset that normal communication between brain and bladder. It gets the nerve signaling working in a proper way. And it's quite amazing because sacral nerve modulation is FDA approved for patients that have not only overactive bladder and urge incontinence, but also patients that have urinary retention. So it can help the entire spectrum of bladder disorders where you're urinating way too much and can't control it, and you're not able to urinate at all. Somehow it kicks the brain and bladder into sync, and it gets you urinating either less or more, whatever is what's needed for you. So it's really cool technology when you think about it like that. It also is what helps with fecal incontinence. So if you have patients that have both overactive bladder, urge incontinence, and fecal incontinence, this is a fantastic option because it's one sacral nerve modulator. The same system helps the overactive bladder, the urge incontinence, and the fecal incontinence. The therapy is trialed either in a simple in-office or outpatient surgical procedure. It's either called a percutaneous nerve evaluation or a first stage sacral nerve modulation. And with this trial, what we're doing is basically giving you a test run to see how are you and your bladder going to respond to sacral nerve stimulation. And with this trial, we place small wires, typically small wires, in the backside through your sacral third foramina, which is, if you can see on the screen here, kind of depicted here. There's this little hole in the sacrum, and the sacral third nerve sits just inside of there. So we place these wires through that. I personally like doing these in the operating room so I can use fluoroscopy, which is X-ray in the operating room, to help guide placement so that I know I'm getting this in the right spot. The trial is only as good as the placement of the wires, okay? So we want the wires to be sitting in near contact with that sacral third nerve. They're taped in place for a period 3 days. Some people do 3 days, some people do 5 days, some people do 7 days, just depends. And sometimes longer in certain circumstances, but they're taped in place for your trial, and you keep a diary of your symptoms. What we're hoping to see is that whatever the reason we're putting this in, whether it's urgency or frequency or urge incontinence or fecal incontinence or retention, that over the period of your trial, you see significant symptom improvement as evidenced on your pre-sacral nerve stimulation diary and during your trial diary. And hopefully we're seeing about a 50% or so improvement in your symptoms. That would indicate a successful trial and that patient is a candidate to move on to full system implant. And with full system implant, we would be placing a small electrode, which is similar to the wire. It's a little sturdier. It's got a few more points of contact with the nerve, and it's only placed on one side or the other. With the test run, typically we'll place wires on both sides to see how it goes. But with the actual implant, there's an electrode, a permanent electrode that goes in place, made through a similar, poke hole in the backside, a small incision to place it in. That lead is tunneled under the skin to a separate site where a battery exists and is placed, connected to that, and then the skin is closed and everything is contained at that point. So during the trial, there are some external wires and batteries, but then one of the nice things about the more basic trial is that there's no cuts, there's no incisions. At the end of your trial period, the wires just pull right out. You barely even need a Band-Aid. It's not painful. There's no risk of, or minimal risk of infection, and it's generally a shorter trial, which is easier on patients because during the trial you might need to use a sponge bath or be kind of ginger with your activities. Then when it comes time to put the device in place, it's a relatively straightforward, minimally invasive procedure done under generally an IV sedation, typically not a full general anesthesia. And, the recovery is quite quick. I ask patients to take a couple weeks of taking it easy just so things heal well. But that's it. I mean, I don't have too many restrictions on them getting back to their normal activities. They can eat and drink like normal. They can shower the next day. There's nothing like that. And the therapy starts working right away. It's quite amazing. During the trial, I often will get updates from my clinical staff, who's kind of keeping track of my patients for me. And usually that afternoon, that evening, we're getting good reports back that they're already seeing differences in their urgency and their leakage episodes. The number of pads they're using has gone down already. So compared to the tibial nerve stimulation, which can take 3 months to really see a difference, it may take 3 hours to see a difference with sacral nerve modulation. It's constant direct stimulation of your bladder nerve, and that works much more quickly than peripheral intermittent stimulation of the tibial nerve. Okay, so that's a different way of thinking about it. A little bit more invasive, but much quicker. The batteries in these systems, there's a variety of different ones out there on the market, but the Axonics battery is a rechargeable battery. That rechargeable battery can last 15 years, sometimes more, depending on how much stimulation is being required for an individual patient. And that's with having to charge the device once a month for about an hour. So the charging burden is pretty darn low. I kind of already started going on this, but the Axonics therapy is one of the sacral nerve modulator technologies that's available, and it is FDA approved for overactive bladder, urge incontinence, fecal incontinence, and urinary retention. Non-obstructive urinary retention, meaning the patient doesn't have prostate problem or that's already been dealt with. Okay. And women can have non-obstructive urinary retention too. I want to make that clear. This is not just a male's problem. Females can have urinary retention as well. Shy bladders, incomplete bladder emptying. It can affect both, but it does happen more commonly in men. Again, it's just trying to restore normal communication between bowel and bladder, or brain and bladder and brain and bowel. This is what sort of the test run apparatus looks like. And this little white piece is the small external stimulator that during your test run is worn discreetly against the body. The small wire here is the lead that goes in place. So you notice on that, there's no tines, it's not pointy, it's thin, it's flexible, it's not painful at all. So that is put in through literally just a needle poke. So imagine getting your blood drawn. That's what I use to access the nerve. And I can take a little inner portion out of that needle, drop the wire through, take the needle out, and all that's left behind is that wire. That wire's then connected to the small external stimulator. It's really well taped into place for your trial period. And then you've got this hand piece here, which is your patient remote control. It allows you to turn the device off and on, up or down, to get the stimulus that you need. If you move forward to the full implant, the electrode that we use is slightly bigger than that wire that you saw, and it's got some little tines on it that help hold it in place, but it's then tunneled over to this battery. This is the Axonics rechargeable sacral nerve modulator battery. This is it compared to the size of a quarter. So you can see it is not very big. It's pretty thin. It's very light. I have to make about a 1-inch incision to put this in, so it's pretty dang small. And you know, it's all tucked in on the back side, so we can kind of hide it under your panty line or your bathing suit line, so it wouldn't have to impact you in that way if you're still young and pulling off your bikinis, okay, or you got your swim trunks on and you don't want people to know you have a nerve stimulator. We can hide that. These batteries designed to last 15 years, sometimes will last longer. As long as you keep them charged up, they should stay working for you. The nice thing about the Axonics system is that it is completely MRI compatible. As long as if you're getting an MRI for any reason, you do need to let the MRI tech know, or the radiology department know, that you have one of these systems in place. They generally will have you turn off your device, but the device does not have to be removed, and you really don't have to worry much about the sequencing of the MRIs being changed for the Axonics brand device, which is a real nice benefit to this system. You can have 1.5 Tesla and 3 Tesla MRIs. These are just differences in the strength of the magnets, which hopefully you guys don't need to know a whole lot about. This control system is very intuitive, very user-friendly. It is about the size of a key fob, so it fits on the keychain, pretty discreet. It is not hard, and that's one of the nicest things about this systems, is that Axonics has really thought about it from a patient-centric point of view to make the controller unit for the patient as simple as possible to use. This is the charging belt, and there's a little puck that goes on it. It's situated over the site of the battery. You charge about once a month. It's 60 minutes or less. They've done studies on patients. I think this was around 108. It was either 129 or 182 patients or so that had the Axonics therapy system implanted, and almost all patients found that charging really wasn't that much of a burden. After 2 years of therapy, even, you know, they hadn't grown tired of it, they hadn't forgotten. 94% of patients found that the frequency of charging required and the duration of the charge was acceptable. 98% of patients charged every 7 days or less frequently. So really, it's not hard to charge. You don't. I wouldn't let that stop you from getting this type of a system. There are systems out there that have non-rechargeable batteries. There may be patients where that's the better choice, and that may be patients who are forgetful, that don't have the help around the house to remember to charge their device. So there are going to be circumstances where that might be a better option. But the rechargeables are really nice, because the non-rechargeables that are currently available, you know, don't last quite as long as the non-rechargeable. So patients have to go back to the operating room to have those devices changed a little bit more frequently. The non-rechargeable batteries are slightly bigger, requiring a slightly larger incision to put in, okay? All right, 93% of patients found that they had meaningful and lastful improvement in their urinary symptoms in 2 years, you know, within their first 2 years of having the device. So then that speaks a lot. There's a lot of options out there for overactive bladder urge incontinence, where if you look at longer term data, how long does that patient continue using that therapy? Let's talk medicines. You know, very few numbers of patients stay on medications long term, especially the anticholinergics. It's nice to have something that we can offer patients where we know that the vast majority of people that had a good test run, that were successfully implanted, are still seeing improvement and are happy with their symptom response years out from their initial implant. Okay, and 93% of patients, this is from the same study, 93% of patients that study said that they would undergo this therapy again. Also, that speaks volumes about how happy patients have been with this type of an implant. It is usually kind of a scary thing for patients to think, oh, I'm gonna have this device in my body, this foreign device, and it's going to set off the alarm detector at the airport, and I'm going to have to worry about this controller, and is it going to hurt? You know, there's all these things that oftentimes patients have all these hesitations about doing a sacral nerve stimulator. And I try to equate it to, look, you know, patients use pacemakers for their heart, because, you know, we can't control our heartbeat either, and sometimes it gets out of whack and awry, and the pacemaker helps to reset their heart so it's beating normally. This is very similar to that. The heart and the bladder are very similar organs. it's, once I kind of explain that and patients think, oh, well, yeah, I know friends that have pacemakers, or I know friends that have spinal cord stimulators, or for pain, or for whatever the case may be, deep brain stimulators, these are similar types of therapies. And patients are actually getting really good response out of them, not needing to take medications with all these side effects. It becomes a lot easier to kind of wrap your mind around it when you think about it like that. Okay, so I'm going to move on to stress urinary incontinence. Okay, so again, that's leaking when you cough, laugh, sneeze. Super common, tends to affect younger patients as well, those that have had early pregnancies, vaginal delivery. So we may see a younger patient population that come in for stress urinary incontinence than we do overactive bladder urge incontinence, but certainly we see all ages, all genders for these problems. Stress incontinence is much more common in females than in males, though. Typically for males, it's going to be patients who've had some sort of prostate surgery, typically radical prostatectomy for prostate cancer. And the stuff I'm talking about today is not going to apply to those specific scenarios, but for female stress urinary incontinence, that's more what I'm focused on here today. The incontinence issue. So what's happening here again is an anatomical issue with the pelvic floor muscles surrounding the urethra not being able to adequately contract or coapt during times of increased intra-abdominal pressure, where there's pressure being pushed on the bladder and it's forcing the urine out. Under normal circumstances, when you cough, there's a reflex that's built in that allows the pelvic floor sphincter to sense that and immediately contract so that urine is contained in the bladder and doesn't squirt out. But for some patients who either have laxity of the pelvic floor structures, the urethra, the periurethral fascia, the sphincter muscles may be insufficient or is weakened for whatever reason, those muscles can't contract, the urethra cannot coapt, urine squirts out. There are a lot of treatment options for this, just as there is for the others. This is also a very common problem, so you're sensing a theme here. 1 in 3 women will experience stress incontinence at some point in their lives. That's a huge number of women. Not always, is it something that they come in to see us for. Oftentimes it's mild and transient, may happen after delivery, but with some pelvic floor strengthening exercises, maybe physical therapy, it gets better. But oftentimes it persists. 60% of women say that symptoms impact their lifestyles. And this is, again, because of feeling like they can't go out and exercise. Sometimes they'll leak during sexual activity. They are afraid to go out and play tennis with their friends for fear of having an accident. They can have accidents at work. So it's the same sort of thing over and over again. Stress incontinence is not excluded from the quality of life and productivity impact that the other types of incontinence have. For stress urinary incontinence, there's a variety, and even this slide doesn't do it justice, but there's a lot of treatment options that are out there. The most commonly utilized are pelvic floor physical therapy and pelvic floor strengthening exercises. There are vaginal laser therapies, radiofrequency ablative therapies. There's electromagnetic chairs that you can sit on to try and help strengthen the pelvic floor muscles. And there are pessaries, which are little inserts that can go into the vagina to give a little pressure back towards the urethra to help prevent the leakage. But by far the most commonly utilized active therapies, especially surgical therapies for stress urinary incontinence, are slings, mid-urethral slings, and there are also vaginal bladder neck slings, which are less commonly utilized. And there's something else called bulking, which is a lot less invasive. And bulking is really, over the past couple years now, since Bulkamid came to market here in the United States, has really shifted the treatment of stress urinary incontinence for a lot of providers like myself and for patients, because we finally have a bulking agent that works well, that's safe, that is long lasting and doesn't cause really hardly any side effects. So I'm excited to share that stuff with you today. So for stress incontinence management, same sort of things. Diet and lifestyle are important. Weight loss if you're overweight, pelvic floor strengthening exercises, quitting smoking, controlling diabetes, getting off steroids, all those sorts of things matter. Kegel exercises, as I described for the overactive bladder urgency issue, can be very helpful for stress incontinence as well. So those are often utilized. But when those things fail, we're either resorting to a surgical operation called a mid-urethral sling often, or we will resort to bulking. Slings are surgical procedures where we place typically a small mesh hammock behind the urethra to lift and support it. So it's placed through a vaginal incision. It's usually pretty small, about, maybe not more than the size of my thumb. Plane is created between the vagina and the urethra, and then depending on the type of the sling used, of which there's a variety, the sling is placed, and then tension to be sitting under the urethra, not in direct contact with it. You don't want to over tighten it. You don't want to cause problems with the patients. You're, being able to urinate, but you want to have enough support there so that when you get back to your normal activities and your urethra starts to fall or it can't quite close, that sling can help give enough support that the urethra will be able to close. They are very successful. They have good long-term success as well. And for many, it's considered the gold standard of surgical management of stress urinary incontinence. But for all patients, it's maybe not the best option. For patients who have bothersome stress incontinence, but maybe aren't done having children, this is maybe not the best option. Mesh slings, or any type of sling for that matter, can be sort of pushed out of place or dislodged if patients are pregnant and have another vaginal delivery. So in that scenario, it may not be the best option. Patients who have poor quality to the vaginal tissue, who are on steroids, who smoke, who've had prior issues with of mesh down below through vaginal incisions causing extrusion or erosion, may not be the best option for another mesh sling. There are other types of slings that are not made out of mesh that are often used. They're called pubovaginal fascial slings. So those are options. They're a little bit more involved and sort of outside the scope of this discussion. But slings are quite good options. They work very well, especially for the patients who have what we call hypermobility of the urethra, where the urethra is kind of falling out of its normal position, and this helps to lift it back up. In patients who either aren't good sling candidates, maybe we've already had a sling and it's not quite working well enough, who have any of those health conditions that I just mentioned, who may preclude them from being a good mesh sling candidate, or who really don't have hypermobility of the urethra, they have more of an intrinsic sphincter problem where the sphincter just can't tighten enough around the urethra to cause it to close, bulking may be a better option. And in the past, we've really had quite unsavory bulking options, but now we've got something called Bulkamid, and Axonics has got Bulkamid under its umbrella now, which I'm super excited about. And it's been a game changer. Okay, it's been an absolute game changer for use of bulking agents for stress urinary incontinence. This is a hydrogel, or a water-based gel, which is inserted under the mucosa of the urethra by using a small camera and a needle. There are no cuts, there's no incisions. So the camera goes into the urethra, the needle goes through it. We can see the urethra, and we inject the medicine right under the mucosa of the urethra to create essentially cushions. Okay, we're going to call them cushions. And this just causes the urethra to kind of plump up. And over time, that volume of that hydrogel that is injected, it stays there. Your body actually incorporates into it. It does not cause any kind of fibrotic reaction. There's nothing particulate in the material, so it doesn't migrate and cause problems in that way. Where we put it is where it stays. It's just in stark contrast to a lot of the older agents that we had to use for this, which did not last very long and had problems with migration and fibrosis. So weren't very frequently utilized, at least not in my practice. Bulkamid has changed that. And so it's nice to be able to have an option for patients who maybe don't want a sling or aren't a good candidate for a sling, or who really don't have that hypermobility issue. Bulkamid is actually FDA approved for the stress and mixed incontinence. It is able to be done in the office under a local anesthetic. Oftentimes it's done in the operating room under either a local anesthetic or a sedation, or sometimes a full general anesthesia, depending on the patient's pain tolerance and what they think they're willing to go through while they're conscious. But it's a quick procedure. It usually takes only 6 to 10 minutes to do.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
It's implanted to create these cushions along the urethra to restore that proper seal, assisting the natural sphincter mechanism. It's not replacing it in any way, but it just narrows down that lumen. The cushions are moldable for a period of time, so it is hard to overdo it, so to speak. About 68% of patients with one injection will be, satisfied, dry, happy. A subset of patients will choose to have a second injection. That gets patients to about 80% success rate. And the nice thing about this is that the long-term data shows that at least out to 7 years, patients who have seen success with Bulkamid continue to enjoy that success. So we're not seeing loss of efficacy over time. So it's, 92% of women in this study presented in the Journal of Urology back in 2020 reported being cured or improved following their treatment with Bulkamid. I think I'm running out of time, but again, it's just showing very good longevity, which is in stark contrast to some of the older bulking agents, which we used to have. So if you've heard of those in the past and we're maybe shying away from them from outcomes data, there is something new out there that you could talk to your physician about, see if you are a candidate for that. So I think I'm going to, I'm kind of at the end of my slide set now, so I'm happy to open it up to any questions. I do see one that I got. What is the Mona Lisa procedure? So the Mona Lisa is a vaginal laser therapy, uses CO2 laser therapy, which helps with a variety of different conditions. It can help with vaginal atrophy. It can help with laxity of the pelvic floor structures, which can lead to stress urinary incontinence, pelvic organ prolapse, painful intercourse, vaginal atrophy. Often, I guess in the past, it was really often used for patients that have had breast cancer and there was concern about them maybe not being able to safely use estrogen-related therapies. And this is a way to help improve the quality of the vaginal and perivaginal tissues in terms of their collagen and elastin deposition. So it is FDA approved for those things. It is not typically covered by insurance, but it can be the right option for some patients.
If you want to kind of run through maybe a quick kind of like what's the top question you get for both, that might be helpful while folks are filling out the poll question.
I use kind of the most common question I get on Bulkamid is, what's my downtime, and how long am I going to take to recover, especially when compared to the slings. So Bulkamid is, it's outpatient procedure. It is done again under a local or in the operating room under a TIVA or IV sedation or full general. So depending on how you choose to have it done that day, I mean, some people drive in for their appointment, they leave, and I let them get back to their normal activities right then and there. I don't really have any type of restrictions. If they had a general anesthesia, then of course they can't drive that day and need someone to stay with them, but that's it. There's no real restriction in terms of you can't exercise or work out or have intercourse. You can get right back to your normal activities, which is a huge benefit for some patients. Some that are super active, our younger patients that are athletes that come in that are having all this incontinence, but are in the middle of training for their marathons, they might be a good candidate for Bulkamid if they can't commit to taking time off their training to have a sling. So that's probably the number one question I get on the Bulkamid. Usually when I discuss it with them, it kind of speaks for itself in terms of, its efficacy and everything. For the Axonics, I guess the questions I get, I mostly went over in terms of kind of what to expect with the trial procedure versus the actual implant, the recharging, protocols and everything, and the expectation along whether they're going to need to have multiple revisions over time. And generally, given our patient population is on the less young side of things for most of this stuff, not all of it. They may have one battery change, or if they're getting the Axonics system. So the burden of that overall is not too high. And again, it's done under more of a sedation and IV anesthesia than it's a full general anesthesia. So it's not, it's not major surgery. That's, hopefully most of the stuff I kind of touched on. I know I went kind of overboard. You can see I'm passionate on this stuff.
That's awesome. We had a question come in about PTNS can be administered to either leg.
Typically, yes. Now, some people that may have extreme swelling or a cellulitis in a leg may not be a good candidate for one reason, in one leg or the other. But typically, yes, it can alternate between legs.
We have questions on both procedures from an insurance standpoint. I know that's can be a loaded question, but from your perspective,
the answer is for any individual patient, we have to get authorization from their insurance. Some insurances won't cover bulking agents, and some will. Some have specific criteria, and so it's a process that we have to go through to get that authorization before we do it, so that nobody gets an unexpected bill or non-covered service. I also see, are there physical exercises for men to control leaking? The same exercises, Kegels can be done by males and females. We have pelvic floor physical therapists who can work specifically with male or female patients to try to help them hone in on the right muscles to work on. There's websites that you can visit that have lots of pelvic floor strengthening exercises for men and women. Our office, we've got about 6 or 7 pelvic floor physical therapists who are happy to see males and females to work on a variety of bladder symptoms, whether it's stress incontinence, urge incontinence, pelvic pain, ED. I mean, they help all sorts of pelvic floor issues.
Dr. Mobley, I think that's all the questions that we've received. We want to thank you for your time this evening in doing this. For the patients that are on, there's a phone number that's been on the screen, or visit urologyaustin.com to find out more information, or call Dr. Mobley's office. Dr. Mobley, is there anything else you want to end on?
No, but if I can be of help, don't hesitate to call my office and get an appointment. Thanks for sticking with me for a little. I ran a little over tonight.
Yeah, that's quite all right. Thank you for your time, and thank you.
You're welcome.